Bismillah ar-Rahman ar-Rahim. Today, our guest lecture is on the aortic dissection, and we are very fortunate that Professor Yusuf has actually accepted our invitation to present on aortic dissection. Professor Yusuf has been trained in Nottingham and Perth, and then joined BSUH in 2002. He introduced endovascular aortic surgery and carotid surgery under local anesthesia to Sussex and helped develop the regional vascular service. He played a pioneer role in the development of endovascular aortic aneurysm repair and performed the first endovascular repair of a ruptured aneurysm in the world in 1994. Despite dealing with the most complex aortic cases, he has maintained one of the best outcomes for aortic aneurysm surgery in the UK. He was a Hunterian professor of the Royal College of Surgeons in 1999 and a visiting professor, University of Texas, Houston, USA in 2006. He has edited some of the early books and has numerous high-impact publications on vascular and endovascular surgery. He has served as the tutor in vascular surgery from 2006 to 2009 at the Royal College of Surgeons of England, Director of Vascular and Endovascular Courses at RCS, Member Court of Examiner RCS, Professional Affairs Board Southeast, and Appointment Advisory Committee of Royal College of Surgeons of England. He is a past chairman of the British Medical Association Britain Division. He is an honorary chair and trustee of the Sussex Stroke and Circulation Fund. He was a member of the Training and Education Committee and ex officio member of the Council of the Vascular Society of the Great Britain and Ireland from 2006 to 2009, and Vascular Advisor Southeast Thames 2010 to 2011. He served on the first SAC in the vascular surgery and served on the National Selection Panel for the General and Vascular Surgery. He was an elected member of the Council and the Trustees of the Vascular Society of Great Britain from 2017 to 2022. He served as a module lead for the surgery of BSMS for a decade and is the lead for vascular surgery for BSMS. So it is a very impressive career, and we are really thankful to Professor Yusuf for his precious time, which he will be giving the wisdom how to deal with the aortic dissection. Yes.
बहुत शुक्रिया आपका, and I'm humbled for the very kind introduction. तो अपने हमवतनों से तो उर्दू में हम कलाम करने की ख्वाहिश होती, लेकिन ना मुझे ज़बान पे इतना कंट्रोल है, जहाँ तक इस्तिलाहात का ताल्लुक़ है तो वो भी मुयस्सर नहीं है. हमारी जो डिक्शन है तो अंग्रेजी में बात होगी. Okay, so I will try to share my personal experience of managing aortic dissection and use cases to illustrate various diagnostic challenges and technical challenges that are encountered in the management of this condition. For most of you, you don't need any introduction to the condition, but if there are any juniors in the audience, then it is a split within the layers of the aorta, and we're not sure exactly whether it starts as an intimal tear due to shear forces and hypertension or weakness of the underlying structures, or does it start with a hematoma within the wall of the aorta that then leads to dissection, because we do see many patients who present with intramural hematoma and then proceed to full-blown aortic dissection. So for the purposes of description, aortic dissections are classified most commonly according to a classification proposed in early 70s from Stanford, type A and type B, and also the DeBakey classification, which are three categories, 1, 2, and 3. So essentially, the important distinction is whether the ascending aorta is involved or not. If the ascending aorta is involved, then in Stanford, it's type A, and the dissection may extend further down to aorta and iliacs. And type B, where the dissection starts distal to the subclavian artery origin. And that's the important distinction because the management of the two very different. The natural history of the two is very different. But more often, it's very rare to have a type 2 DeBakey dissection where only the ascending aorta is involved. Overall, type A is more common based on the epidemiological data from the International Registry for Aortic Dissection. But again, these data come from tertiary centers where patients have been received with aortic dissection. So we really don't know a lot about the true epidemiology of this condition in the wider population as such. But for the purposes of this talk and for management, again, type A involving ascending, type B not involving ascending aorta. Now, like all disease conditions, we'd like to put them in different categories, but there are some dissections which don't fit into type A or type B, and they're dissections that are starting within the arch, and they've been classified as non-A, non-B, and then sometimes this is a patient who is awaiting repair. I'm planning this in the next few weeks, who had an ascending type A or type 2 DeBakey dissection confined to this area, repaired surgically a few years ago. And now he's got an expanding false lumen aneurysm, 6 centimeters, in the visceral and distal abdominal and iliac segment, but the descending thoracic aorta is totally spared. So where does this fit into the classification? Nowhere, according to the contemporary classification. So patients do sometimes have odd. And there is now a move to try and use a new type of classification, the TEM, to try and use not only the type, but location of entry tear and the type of malperfusion that may be causing it. But it's something that's not being very widely used, and I would not say much about it to avoid any confusion. So really, we'll talk about type A and type B dissections. How common is it? Well, the estimates based on various studies, so one from Canada shows it's about 4 to 5 per 100,000 of population. A study done in Oxford looking at 8 GP surgery practices with over 90,000 patients. They estimated it to be 6 per 100,000. Study from Germany, again, in a similar sort of order, 5%. And interestingly, in their cohort, nearly half of the patient had not been diagnosed, and this was diagnosed post-mortem. In China, again, there's a different demographics, but the estimated incidence is 2.7. And I'm not sure whether it is less common in the Indian subcontinent, or is it something which is not often diagnosed because of obvious reasons. We need access to good quality healthcare. You need access to CT scans, etc., to make a diagnosis. Hypertension, which is an important risk factor for dissection, is no doubt very common in the Indian subcontinent. So I'm not sure, perhaps those of you working in Pakistan as vascular experts might be able to shed some light on that. Now, it is a serious condition in that, and again, we're talking about these patients who have finally reached a diagnosis by presenting to a specialist center, but the outcome is still pretty poor for patients with aortic dissection. Now, the reassuring thing is that for type B aortic dissection, the natural history is relatively benign, and we seldom have to intervene on these patients. So the important message again would be that diagnosis of aortic dissection can be challenging, can be difficult, and it's not unusual for it to be missed, even in the large hospitals in the United States and Europe and Britain. And according to some estimates, even those patients who get to hospital, the diagnosis is often missed or delayed in nearly half of them. So the message that's being sent out through the College of Emergency Medicine and other groups is to think about aortic dissection in any patient who presents with atypical chest pain. And I'll give you an example of a patient who came to us in 2016. So a 76-year-old lady, she was fit and well and active. And she was at a charity event carrying some heavy flower pots here and there and developed chest pain and some interscapular pain. And she didn't think much about it, went home, tried to rest, but her condition did not improve. So the husband called an ambulance, and CCAM is for Southeast Coast Ambulance in our region. And she was taken to the hospital where the vascular center is and cardiac center is located as well. And she presented with this history of central chest pain for an hour, radiating to back, hot, slightly nauseous. Past history of atrial fibrillation and hypertension was documented. The usual assessment was done. It was documented that the pain was quite severe, 8 out of 10, central pain radiating to the back, worse in back, worse on movement and palpation. And she had flown back 3 weeks previously from Australia. So at this point, they're thinking about acute coronary syndrome, pulmonary embolism, possible cholecystitis, and so on. And further assessment, she's found to be hypertensive, 180/70, but not tachycardic. Otherwise, she's okay. And the impression at this stage made by the A&E doctors is that maybe she has got something like gastritis, something non-specific. And now the pain is more epigastric and radiating to the back with nausea and vomiting. So in order to exclude acute coronary syndrome, they have a plan and then to reassess the patient. And if the troponin is negative, 3 to 4 hours post, and the amylase is also negative at this stage, chest X-ray is normal, patient is feeling better, so she's sent home. So ECG at this stage, again, does not show any ischemic changes, but there are changes consistent with long-standing hypertension and left ventricular hypertrophy with tall T waves, as you can see here. So sent home, and this is the chest X-ray that she had prior to being sent home. And then she presented again, not feeling very well, to her local hospital, which is in Eastbourne, on the 5th of May, 3 days later. And on the chest X-ray here, they can see a pleural effusion now and some shadowing in the mediastinum, which is present here, but perhaps more appreciated on this one. So now she has a CT scan, which shows that she has a type B aortic dissection with large effusion, and she's transferred back to our center. And she's managed initially with pain relief and beta blockers. So we used labetalol infusion for these patients, and that's exactly what the medical therapy has been over the past 4 decades. But despite controlling her blood pressure and pain relief, and despite some thrombosis of the false lumen, she continued to have pain and expansion from 4.7 to 5.4 centimeters. And we then went ahead and treated her. As the first step, I did a bypass from the left carotid artery to the subclavian artery. And this is through a single supraclavicular incision in this area. And the purpose of this bypass was to maintain antegrade flow in the vertebral artery on the left side, because she would have required coverage to reduce the risk of a spinal cord ischemia. And having done that, so this is the carotid to subclavian bypass here with an, unfortunately, there was a wide separation between the subclavian and carotid artery to give us more space to put our graft here. And this was treated successfully by a stent graft here. Now, this is these are X-rays belonging to two patients in their late 50s who have presented to emergency department with chest pain. And the question is, which of the two patients has aortic dissection? I'm sure all of us would say patient B with this abnormal shadow in the mediastinum, but the patient A doesn't look too bad. But this is the CT scan of patient A. So he has got a type 1 or type A Stanford dissection is starting in the ascending aorta and making its way all the way down into the abdomen. So he goes an emergency repair or replacement of the ascending aorta with a Dacron graft. And this is in 2012. And the remaining dissected aorta was monitored with serial CT scan and MR scan. So we tend to use more MR aortogram these days to avoid repeated exposure to CT and radiation. And in 2020, this had expanded to a very large size. So we then had to think about doing something here. And this was managed by a redo surgery, I'm afraid. So a redo sternotomy, and it involved debranching. So now the arch vessels were included in the open repair. And a Thoraflex graft, which is made by Vascular based in Scotland. And it's a stent graft which can be deployed antegrade down the true lumen from above here. And so this is a procedure that was carried out for him. And this is a follow-up CT scan showing that the false lumen has mostly thrombosed, but the distal false lumen remains open and requires further treatment. So he's awaiting treatment of the distal part with a custom-made fenestrated stent graft, something similar to the case there you were talking about at the beginning of this presentation.
Very interesting. At this point, you have rightly said that the chest pain may be the first of the presentation, and how often ED doctors misses this diagnosis in Scotland or in UK. It is well known that any patient who comes with a chest pain goes for a CT scan, because I found that one of the patient has actually chest X-ray was misleading even in that patient. So which of the patient presenting with chest pain undergoes CTA? Okay. Is there any protocol for that, or it is just awareness which is being developed?
Yes, so there are some guidance about it, Zia, and I might come to that towards the end again. But generally speaking, there are not. So the College of Emergency Medicine has created posters to be put in A&E department everywhere in the country to say that if you've ruled out acute coronary syndrome, and particularly if the patient is hypertensive. So my advice is that the clue is usually and invariably these patients have very high blood pressure on presentation, often 220 systolic, 200 systolic. The difficulty is that they are often young people as well, in their 50s and 60s, with no previous history of cardiac disease, etc. So there is a feeling that maybe they've got some degree of gastroesophageal reflux or something else. So yes, hypertensive patients, particularly patients who have got very high blood pressure, then think about doing a CT scan on those. That would be the advice, certainly. And
this is the message I wanted to convey, that in our setup, people actually, even in emergency physicians, doctor, this diagnosis never comes in their mind. They only go for EKG and think this can be only MI, but this is one of the diagnoses which can be life-threatening. Yeah. So any patient who's young with hypertension one has to.
Yes, absolutely. High blood pressure, I think, that's an important clue. So if somebody has got, newly diagnosed hypertension, poorly managed, whatever, and they are hypertensive on presentation, and if it's type A, the pain will more be central, anterior pain. If it is purely type B, then often it will be intrascapular as well. And the difficulty is that 700,000 patients present with chest pain to A&E department in the UK every year.
Oh.
And only 1 in 400 may have dissection. So you're talking about if you do CT scan on everyone,
yeah,
that's
so
difficult. But I think just having that in the back of your mind is important. And the debranching and redo surgery is a major undertaking. It takes a long time. I mean, this is a case we did not that long ago, and we were in theater, all day, exhausted. We tried to do everything in the same sitting, including the stent graft. So, you work. So my cardiac colleagues, Mike Lewis and Amit Modi, we work closely on these things together if we have. So this is another patient who I showed earlier on with presented with chest pain to a hospital where I used to work before in Nottingham. He was traveling past and had chest pain, and in the A&E they found this chest X-ray, so they immediately thought about dissection. And he had a dissection and malperfusion of the right kidney. So they treated it successfully with just a stent graft beyond the subclavian and a stent in the right renal artery. And he came back to Sussex, where my hospital is based now, and I followed him up, and his false lumen aneurysm continued to grow. So this is, you don't see the size very much, but it's quite a large false lumen aneurysm crossing the visceral segment down the iliac on the right side. So I then had to use a custom-made fenestrated component with celiac, superior mesenteric, and both renals, and extend it from the previous stent graft down to the iliac. With extensive coverage of the aorta, spinal cord ischemia, paralysis remains a very significant risk, and the vertebral artery, the subclavian artery, and the internal iliac arteries are therefore then become an important collateral circulation to the spine, and we have to try and preserve them at all costs. So in this case, where the dissection was involving the right common as well, I then used a branched stent graft to preserve the right internal and extend it to the external iliac artery. So that's all sort of repaired now, secure. And fortunately, he had a straightforward outcome from this procedure. But paraplegia remains a dreaded complication of extensive coverage, and that's something we worry about. Now, I showed a slide about doing a carotid subclavian bypass in order to preserve the subclavian, but recently I used this approach of using a fenestration for the subclavian. So there's a hole in the graft here, and I've approached it from the arm to get into the fenestration here, and then put a covered stent graft here to avoid doing the bypass in the neck. And you can see the vertebral artery here maintains antegrade flow. So that's also an option. And various companies are now manufacturing stent grafts with little branches to subclavian. So Gore has got one. There's another company, Lombard Medical, we make the Aorfix graft. They have got a clever little side branch here. So those options are also available now. Now, one of the difficulty with all these conditions is that question about when to intervene. Is there a size criteria at which we should be treating these? Now, there are various guidelines. So European guidelines talk about treating false lumen aneurysm. So patients who have got persistent descending aortic false lumen that has become aneurysmal, to treat them at 5.5 centimeters. But the evidence base is very, very poor. And then some of the American centers talk about, well, if you don't do anything to these, then 60% will need treatment within 5 years. They really can't say that the patient needed treatment. They just go ahead and treated them. So we looked at our own population in Sussex. So we looked at patients who had, over a 10-year period, who had type 1 TEVAR dissection, treated with ascending repair, and they still had false lumen in the descending aorta down to the iliac. And we monitored them with CT scans every year. And of the relatively small numbers, so there were only 51 patients, but over this long period, none of them ruptured their false lumen. Some did grow to 6 centimeters. By then, they were much older and they had the confidence that this is a condition which is not causing any problems, so they elected not to have anything done. And I think I treated only 2 patients in this category. So the chronic false lumen aneurysm that persists in the descending thoracic aorta doesn't appear to be that much of an issue, but we need more studies, and we are in the process of setting up a national study to look at the fate of false lumen aneurysm through the cardiac database, which includes thousands of patients. So we'll hopefully learn more in the next 2 to 3 years. This is another patient case of complicated. So we talked about type A or type 1 dissection. They need immediate surgery, and then we deal with the chronic false lumen problem in a planned way if we have to later on. What about type B? So fortunately, most of the type B dissections are uncomplicated, and they can be managed without intervention with antihypertensive treatment, but some do have some complication. And this is a young man who had stopped taking his blood pressure tablet during the pandemic. He was, people were scared to go out to the pharmacy, to doctors, so he stopped taking it. And he presented with type B dissection. There was very little flow to the right renal artery, and there was some retroperitoneal hemorrhage in the abdomen, although the false lumen was not very large. So I treated him with a stent graft that started here down to the descending thoracic aorta. Then in the visceral segment, there is a dissection stent, which is essentially the same Z stent, but it's not covered with anything. So it allows you to re-expand the true lumen, but you can put it across the visceral branches without having to fenestrate or branch, because it's just the stent, so the blood still flows into the visceral branches. And then I put in a stent from the true lumen across the false lumen into the right kidney. And that managed to restore the blood flow to the right kidney. You can see it is better in-house now on the CT. And then put a covered segment here. And this was a distal component we use for a fenestrated stent graft. So the fenestrated graft comes in 2 components. So it was the second distal component that I used here because he had some extravasation and bleeding in the abdominal segment. And he's done well with that. So this was not that long ago. This is a lady who presented with acute intramural hematoma and an abdominal and a visceral aneurysm, which wasn't particularly large, but she had persistent pain, and I was concerned that if she dissects her aorta, then she might end up in a very complicated situation where we may have to then, deal with all these visceral branches in an emergency. So I treated her with a carotid to carotid and carotid to subclavian bypass. So we managed to debranch everything and put a stent graft right up to the innominate here, because the intramural hematoma was extending all the way up here. And the dissection, had it happened, would have started in this region. And she did fine with this procedure, but then years down the line, so this is 2014, and then 2018, as we were following her up, the visceral segment continued to enlarge to a 6 centimeter aneurysm. So I then had to use a branched stent graft to extend the repair all the way down here. Again, paraplegia was a major risk for her. Unfortunately, she came through that all right. Now, this is another patient, a young patient, 58-year-old, and Turner syndrome is a condition which is also associated with aortic dissection. So something to bear in mind if you have somebody who's got a diagnosis of Turner syndrome, look at their aorta, because they do develop dissection and rupture. So she was known to the cardiologist and cardiac team, and she had a dilated ascending aorta over 5 centimeters. But she also had a saccular aneurysm here, just around the subclavian artery. So we discussed her at our combined meeting, and the plan was for the cardiac surgeons to replace the ascending, and also she had a bicuspid valve. So replace the valve, ascending aorta, debranch, and then I was to come in and put a stent graft here electively a little later. Unfortunately, soon after the bypass operation, she dissected her aorta all the way down. And within a few days of doing that, you can see the true lumen is really compressed here in the descending, and the false lumen has really expanded to a very large size. And this was in June 2020. So I had to then come in on a Saturday and deal with that. So I had to go past her newly implanted tissue valve. My cardiac colleagues, they were there, and I said, look, I'll have to go through here. They said, that's fine, as long as, once you get through between the leaflets, then it's okay. So the Lundquist wire is in the left ventricle, and we put in a stent graft from here all the way down. And this is her follow-up scan. So you can see the dissection here. It looks quite horrendous here, and it all remodels very, very nicely on the follow-up CT scan, and she's fine. Now, this does create the temptation to treat all type B dissections early, because if you can put in a stent graft, they do remodel very well. And then you don't have to worry about the chronic false lumen aneurysm and its treatment with complex fenestrated branch stent graft. But if you change that approach, then you'll be over-treating. You'll be treating many, many patients at a great cost, and then perhaps do more harm than good. So in fact, as we speak, as of last week, a submission has been made from Imperial to set up a national trial in the UK to look at early treatment of uncomplicated type B aortic dissection. If it's funded and approved, then maybe in a few years' time, we will have a little bit more understanding about the impact of early treatment. But really, that trial will need to have at least a 10-year follow-up to tell us if the false lumen expansion matters and makes a difference. Because as I said to you before, in my experience, it's very rare to see patients presenting with ruptured false lumen unless they have Marfan's or some underlying connective tissue disorder. Now, this is a patient who was a very recent one in the last few weeks, and he presented to us with a type B complicated dissection with a 10 centimeter aneurysm of the false lumen down here in the left iliac, with a fistula into the iliac vein and IVC. So he was in quite a state, high output failure, and there was some stranding outside the aneurysm here as well. So I had to go in and we treated him with a stent graft for the thoracic segment, covered a stent graft. So that sort of opened up the true lumen. And then up to here, and this section here is again the uncovered Gianturco stents. Okay, so it has re-expanded the true lumen, but the viscerals are being perfused here, and then the covered stent graft going down to the left external and right common iliac artery. And now I need to finish off by putting this fenestrated component to bridge this segment, and that's been ordered, and the case is now booked for the 15th of next month to be done. Again, the risk of paraplegia is there, and one of the things about these cases is that it's not always easy to find the true lumen with your wires and catheters. So be prepared to come from above, and that's what we did here. We came through the subclavian down here and snared the wire to gain access into the true lumen, because you can be lost.
Can all people keep their mics mute, please? Rehman.
Maybe you can mute as well as the host.
Yeah, I should actually do it. They look like busy surgeons.
Okay. So that's one example. And as I said before, Syed, to your question about, should everyone have a CT scan? That's a difficult one, because the number of people coming through is large in any center with chest pain. Most of them will have acute coronary syndrome rather than dissection. But, hypertension is the clue. So if you have got normal troponin, not normal ECG, but no ischemic changes on ECG, but they're hypertensive, then think about a CT. because it makes a difference. So what are the other challenges with diagnosis? Well, the ECG may still show ischemic changes in a quarter of patients because the dissection may involve the coronary ostia. Likewise, the troponin may also be raised in the quarter of the patients. And the chest X-ray does not have a high sensitivity for showing us mediastinal changes. So, again, a fifth of patients may not have an abnormal chest X-ray to give us the clue. And of course, if they just have intramural hematoma and they haven't progressed to full dissection, which again needs emergency treatment for the ascending aorta, then it may not be seen on chest X-ray. So patients may be, the clue is that may be relatively young without risk factor for cardiovascular disease. One of the blood tests which has generated some interest is D-dimer in aortic dissection. And I'll come to that in a moment. But the message really is to consider a diagnosis of dissection if there is a history of sudden onset of severe chest pain or back pain. And the patient may describe it as tearing pain. I don't know how we will translate that in our languages. We have many, many good languages in Pakistan, so Urdu necessarily is relevant for everyone, but they will describe it in a way that would be, of tearing in nature character. There will be associated symptoms of vomiting, sweating, and faintness because of the autonomic disturbances that come with that. And the location of pain can also change. So if the dissection extends as it's dissected the aorta, the pain will also migrate along there. The history will be of sudden onset of severe pain in most patients. And as I said before, if it's type A dissection, it will be only anterior chest pain. If it's purely type B, then it could be in the interscapular region or back, and then in the abdomen as well. And of course, if it's type 1 or type A extending, then it will have all the other symptoms. Some may present with visceral ischemia, so there will be typical sign of abdominal pain with minimal signs, but a lot of pain and nausea, vomiting with that. Or they may present with lower limb ischemia if the dissection leads to flow limitation in the arteries down the iliac artery. So D-dimer is something which has been looked at in the past many years as perhaps a blood test that might, provide an aid. And the message is that it is raised in aortic dissection, just as it's raised in pulmonary embolism. But if it is less than 500 nanograms combined with aortic dissection risk score of less than 1, and that risk score is based on absence or presence of typical symptoms that I've talked about, then it could be helpful in excluding dissection. So, the key again is early diagnosis. As I said, even in our hospital or many other centers, it is not often picked up, often delayed. But this is a good example. Again, recently in April, the patient developed severe chest pain, tearing, radiating through the chest to the back. And this is a request this is what was written on the CT request to the radiology department. He started getting the pain just past around midnight, called the ambulance and got here and got the CT scan by 1:30, which shows a complicated type B dissection with rupture. Okay. And by 4:30 in the morning, he had this repaired with a stent graft. So this is one of the better stories of early diagnosis and treatment. Doesn't always happen, but if you have a switched on A&E doctor or paramedic or clinician, then this can happen. And this is a good example. So to summarize, the take-home messages really for management of aortic dissection. The good news is that most of the type B dissection will not need an operation. They will respond to medical treatment and they will be fine for many years. And the mainstay is blood pressure control. And how do we control it? Well, it's with the use of beta blockers. So we tend to use intravenous labetalol infusion. And if they need additional antihypertensive drugs, then they can be added. but you don't start with vasodilators. Okay, that's contraindicated. So you want to reduce the force of ventricular contraction, and so the beta blockade must happen first. And if they need additional antihypertensives, then by all means give them, which maybe vasodilators as well. Okay, on top of that. If it's a type A or type 1 dissection involving the ascending aorta, then they need immediate surgery. Okay. The simplest one is ascending aortic replacement, sometimes repair of the valve, sometimes replacement of the valve. But and then there is a lot of debate about just doing that or replacing the arch and putting a Thoraflex graft to help with the future management of the remaining dissected descending thoracic aorta. Now, if it can be done, then of course it's good news. It makes future management easier, but it is a much more complex operation. And as we speak, in most cardiac centers in the UK, I think the majority of patients will still get a life-saving ascending replacement and fight to live another day for the management of the distal dissected aorta. Type B, complicated dissection. The preferred option is endovascular repair, with or without debranching in the arch as required. And this can either be done, as it showed with bypassing the neck, or with fenestration or branch endovascular. Intramural hematoma, again, managed with best medical therapy, but endovascular repair if there are signs of expansion or dissection. And for the management of the chronic dissection, the case here you've got on your table right now, that's a more difficult one, because if the false lumen aneurysm is expanding and getting bigger, then you feel inclined that you have to do something. In most cases, as I said to you, in our experience, that is not necessary. But if, as you say, in your patient is 8 centimeters, then something needs to be done. The European guideline talks about treating at 5.5 centimeters, but if you look at the primary source of evidence, it's very weak. Okay, so we need more evidence base here. But if you need to treat these, then again, it's an endovascular with using fenestrated custom-made implant. The tree lumen is often quite compressed, so how do you size it? How do you choose the right size of stent graft? These things are the challenging issues in planning such a repair. And it really, these patients need to be managed in aortic center. And again, you guys need to think about developing aortic centers where you have all of this. I placed vascular surgical team at the bottom. You know, we might like to think that we're central to the management of these patients, but we have to show some humility, because without all of these, we can't do anything. Okay, so cardiac surgical team on site, vascular surgical endovascular team on site, you know, radiologists, radiographers, and all of these have to be on one side. And when you start managing these patients, then in terms of screening the family members, which becomes an important thing, access to genetics, developing that service as well, because then you're able to pick up patients at an early stage, particularly in terms of surveilling or looking at their ascending aorta, and if they're dilated, then treating them before they rupture or dissect and become an emergency. So these things need to be done. For the future, you know, there is the Chinese are making advances in getting forward and forward, and this is the case in the JAC 2016 about treating the ascending type A dissection with placement of a stent graft here. And of course, the technology with branch stent grafts is there. It still is in infancy. There's high risk of stroke, you know, other complications at the moment. But in the fullness of time, this is again something we are working on, is to, you know, try and find solutions where you can almost go into the left ventricular outflow tract, use the technique that we use for TAVI to replace the aortic valve, and maybe side branches for the coronaries and all that. And actually, this is not just a wild imagination. That team somewhere in Rio, Brazil, they have actually done a case like that. So that's for the future. So I'll stop here, yeah, and can open it to discussion and questions. And I'll stop.
Thank you so much, Professor Yusuf. That was such an amazing talk and such an interesting cases, and every case was actually challenging, I suppose, and that is beyond our imagination. Some of the cases which has been successfully managed. So I welcome everyone to actually, if they have any comments or questions, they can place a chat box or raise their hand. We can do. We have one comment or question from Dr. Aisha. Dr. Aisha has said that, so grateful for the opportunity. What could be the possible treatment option and surgical approach for a patient with aortic dissection starting in ascending aorta, involving the right internal carotid and going all the way up to right common iliac artery, where the renal arteries are being supplied by false lumen, especially if there is no endovascular expertise available in the emergency.
Yes, so I think as a life-saving intervention, they can have the ascending repair, and again, this is something that cardiac surgeons do. And whilst I know enough about it, I wouldn't like to go into too many details because it is an area outside our expertise as vascular surgeons. But yes, in a case like that, the management will have to be in an aortic center where cardiac surgeons have experience of aortic surgery. And I suspect it will be an ascending replacement with a hemiarch. So you then try and address the dissected arch branches, incorporating them into a hemiarch replacement. And for the distal dissected aorta, mostly, as I said to you, unless, if the patients have got connective tissue disorder, Marfan's, or and so on, then yes, they will need something doing because they're at high risk of rupture. But you can use stent graft, you can use some debranching in the neck, and without requiring complex endovascular. So a straight tube thoracic graft can be implanted by all of us, more or less. And you can do the debranching in the neck, as I've shown, and place the graft there. And for the malperfusion of the renals, you can just put a stent or a self-expanding covered stent graft from the true lumen across the falls into the artery. And that can address the malperfusion immediately without having to treat everything upstream, downstream from there.
So we have two hand raised, first from Dr. Umar and then from Dr. Sohail. Ji, Dr. Umar.
Thank you, Mr. Yusuf, for such an excellent presentation. As we were discussing before you started the presentation, aortic dissection is I think quite common in Pakistan. Maybe not as common as it is in West, but we do see a few patients coming our way, and most probably I think it is more underdiagnosed as compared to the less number of cases that there are. I've got a few patients who have come to me, and looking at your presentation, I was just thinking about I think it was most probably 2006 or 2007 Vascular Society meeting when I heard the talk by the late Roy Greenberg about aortic stenting from valve to bifurcation. And I was listening to it in awe at that time, being a trainee, and now things are moving quite in that direction. And you've shown a lot of cases which are almost close to that. The thing which I wanted to ask you, I've got a few patients who are actually with dissection with intramural hematoma, and one thing which I kind of keep an eye on is the lakes or the penetrating type ulcers which these patients start developing at the site of branches, the intercostals in the intramural hematoma. So I wanted to ask you about what is the criteria, when would you want to intervene if there is that kind of penetrating ulcer or a lake in the intramural hematoma, and also the proximal extent of the stent, if you have to do, is it just where the hematoma is starting, or do you go more proximal than that?
It's a difficult one, Omar, because we really have very limited data on natural history of these patients who have not resolved their IMH. So there's no minimal remodeling, and they're now getting these saccular changes here and there. You just have to. I think in most patients, as long as the blood pressure is being managed, I would be content to follow them up and see how they go, rather than intervening, unless, as I said, if there is an underlying known diagnosis of Marfan's, for example, or there's a family history without a genetic diagnosis. My inclination would be to continue with best medical treatment in these patients, the statins as well, perhaps, and antihypertensive medication. But if you have to treat them in terms of extent, I think most of them will be extending from subclavian, just past subclavian, and often you see there's sort of a little hump going across there. So it's not. It doesn't feel comfortable landing into that area. And if there is enough space between subclavian and carotid, then I would take it past subclavian over. And if the extension is not too extensive coverage, then just go with that, see what happens, or treat upper limb ischemia is usually not an issue if the vertebral is patent, which is in most cases. So I would take it past. So proximal landing zone, I would include subclavian in my coverage in those patients. But for most patients, I would be perhaps happy to manage them medically.
Okay, thanks.
Then we have Dr. Sohail and then Dr. Asma. Ji, Dr. Sohail.
Assalamu alaikum. Waquar was a fantastic talk as usual. Thank you very much. Very informative and very good talk. I've just got a quick question. I'd be very grateful if you could just explain the frozen elephant trunk and what the indications are for aortic dissection. Thanks.
So you were supposed to contribute, not ask questions.
Yeah, that's true. Well, you're the expert. I'm just.
This is an area of big debate, Sohail, in the cardiac circles at the moment in UK about whether you just replace the ascending, save the patient, live to fight another day, and manage the chronic false lumen issues afterwards, or you do something more. And in fact, I recently had a patient who is Polish, but lives in Brighton, and she was on holiday in Poland and developed nausea and vomiting, and she was on holiday taken to their local hospital. Anyway, they've made a diagnosis and a fantastic operation where they've done that, and they've also placed this Thoraflex graft. So now I'm monitoring her descending aorta. Her genetic tests have all come back as negative. I mean, phenotypically, I thought she may have Marfan's, but she's so it's not settled. I think in many centers around the continent, people are going with the elephant trunk, stent graft, in acute scenario to help manage the long-term management of the dissected aorta. But in the UK, I suspect most cardiac surgeons are content with just doing the life-saving ascending replacement and leaving the rest alone. So this is something which may develop, but at the moment it's an area of discussion amongst cardiac surgeons. But this, the Thoraflex graft is quite a nice one. You can deploy it antegrade during, during the bypass through the true lumen. And it's quite interesting. They use a big angioscope, almost like an endoscope, not the fine angioscopes that we used to try in the early 90s, to actually visualize the true lumen, to make sure they're in the true lumen, and then put the stent graft in one case. But the other option, which I did with the last case I was showing, was that I did place a guide wire for them from below first into true lumen, And they also have the transesophageal echo during the procedure, so that also helps to visualize the lumens and place the wire.
Ji, Dr. Asma, and then we have Dr. Khalid Makhdoumi.
Assalamu alaikum. Thank you, Dr. Waquar, Yusuf. Thank you, Dr. Ziaur Rehman, for this very interesting session. So my question is regarding the diagnosis of aortic dissection, because as Dr. Waquar said, that it is often missed because it's relatively uncommon. Apart from that, we've been studying in theory that usually patients with aortic dissection present with a difference of systolic blood pressure of 20 in their bilateral arms, and also with pulse deficit. So my question is that, are we failing as clinicians to even consider aortic dissection as a possible differential, because we're not doing a good general physical examination, we're not including the bilateral blood pressures and pulse deficit in our general physical examination, or is it because clinically it doesn't very commonly present in aortic dissection?
So perhaps latter, because it depends, on the involvement. And if it's a type B dissection past the subclavian, then the blood supply through both the subclavians are similar. And if it's a type A dissection, again, it depends on whether there is dissection extending into the innominate or the subclavian. So it's physicians talk a lot about it. It's always there in the textbooks about the pulse deficit or differential 20 millimeter difference and so on. But it's perhaps the more important features are the type of pain, the presentation, the symptoms, listening to the patient carefully, what they're telling you. It's often on the scale of 1 to 10, quite a severe pain. The pain may migrate. It started somewhere up in the interscapular region. Now it's in the abdomen, crushing anterior pain, and nausea and vomiting with that, and hypertension. I think for me, the clinical assessment is a good history, listening to the patient. They will appear ill. I mean, they will be sweaty, they will be clammy, they will, you can tell they're not right. And then hypertension. So for the vast majority, you will find that they are hypertensive on presentation. And I think that is the clue. And of course, you would do the routine things for acute coronary syndrome. And if that doesn't come back as positive, then you do a CT scan.
Thank you so much.
Dr. Khalid.
Thank you, Waquar. Assalamu alaikum, everybody. Excellent talk. I missed your introduction, so I don't know whether you have mentioned it or not. About the timings of intervention for dissection. I recently met Aaron Thomas from Florence, Professor Thomas, and asked this question from him. And his view was that within a week or 15 days, is when you can intervene in such cases, the acute dissection, type B I'm talking about. So what is your view? I don't know whether you mentioned it in the beginning. I know that the evidence is not very strong, and you have mentioned that there will be a trial coming up. But at the moment, while we don't have any answers, what do you think we should be, if we have to intervene, the timings of intervention?
Salam Khalid, good to hear from you. So no, I didn't talk about it. So it's a very important point Khalid has raised about the timing of intervention. And people have experienced that when the patients were treated very early on, there was a higher risk of retrograde dissection and complications. So some patients developed, type A from type B because you have a stiff guide wire, so you've got delivery system up there, you're placing stent grafts, and sometimes these stent grafts shouldn't have, but in the past had barbs and various things to promote dissection. So people have tried to categorize them as hyperacute, acute, and chronic. And so there is a general consensus amongst people who have treated type B dissections that it is probably not a good idea to treat uncomplicated type B dissection in the first week or 10 days. If you're considering doing something, and that's what the trial protocol will say, Khalid, as well, the NHIR application that's gone in. So we'll be randomizing patients beyond 10 days of onset of symptoms here. So generally there is some reluctance to treat them within the first 10 days because of the perceived risks of retrograde dissection and complications.
The other question is another question. That is okay. Can I ask another question?
Yeah, sure. Yeah.
The other thing was that if the dissection extends beyond the vessels in the abdomen, but they are not involved, all the vessels are coming from the true lumen, you have to you stent it to cover the flap. But on the other hand, what is your protocol to use a non-covered stent for the area of where you get all the vessels out?
Exactly, Khalid. So the couple of cases I showed earlier on, where exactly that's what I did. So I had a covered stent graft in most of the thoracic aorta, and then the uncovered stent across the visceral, and then further covered below the renals. And in one patient where there is persistent flow into the false lumen down to the left iliac, which has become a 10 centimeter aneurysm with a fistula, I'm going to now have ordered an urgent fenestrated component to bridge that within those things. So yes, so absolutely that sort of scenario you described, I would use the uncovered Cook stents, the dissectionist stents for that segment. So it allows you to re-expand that segment without having to do anything fancy. Yeah.
Thank you.
Your talk is has generated a lot of interest, and we are beyond the time, but there are two people who want to ask questions. Is it okay if I ask? One is
Please,
Dr.
yes.
Numan Sheikh, and one is Dr. Muhammad Tai. Dr. Tai has raised comment that it was very comprehensive talk. You mentioned starting UK-based trial. Is it different from the adsorb? And instead, regarding question from Umar, do consider nectar Waquar technique for expanding hematoma sac. Lastly, do you use spinal perfusion in every case?
Okay. So taking the first question about the UK trial, so the adsorb trial, which again looked at uncomplicated type B using the Gore device, it's a similar sort of protocol, but they had, it was a short-term study with nearly 60 patients randomized, whereas the UK trial, the aim is to try and see the longer-term benefit. So what happens to the chronic false lumen, like the case Zia has got with an 8 centimeter or our experience, so of not seeing too many ruptures. So that's the question being asked in the UK trial. And instead, as you know, is a registry. So this is a randomized trial we're looking at. And Omar's question.
And do you use spinal
drain
in every case?
Yeah, no, Umar, no. So especially for the emergencies, we don't, but try to preserve the antegrade flow in the vertebral and try and preserve the internal iliac arteries and be prepared to put the drain in if anything develops later on. For elective thoracoabdominal aneurysm, yes. So for this man, the last patient, I'm going to put the intervening fenestrated component. It'll be a planned one. He's already got extensive coverage. So we will put a spinal drain for him, prophylactic.
So if you have good question, Dr. Numan, you can ask. Otherwise.
Hi, hello. I just need to ask, thank you very much. It was a very informative session. Just a question, especially, I think Dr. Zia, you will be able to answer better probably. It's related, if you get, for example, a patient with type B dissection with malperfusion, and as Professor Yusuf mentioned, it's a preferable option is endovascular, and almost always we do the endovascular coverage of the dissection point. So so far as I know, the AKU started doing the EVAs. I'm not sure current status. So what would be your option if there is a patient with type B dissection with malperfusion?
Yeah, still because the fenestrated graft takes time, and we have not a mature setup for doing complex EVA. So our option will remain doing these open surgery. As I have discussed one of the case, which was having the 8 centimeter aneurysm in the thorax. It was starting from subclavian artery up to the diaphragm, and it was expanding aneurysm. We went for the bypass, left thoracoabdominal incision, and replaced with a Gore-Tex, and patient is fine. But about 4 or 5 years down the road, the lower segment, which was riding from the diaphragm up to the iliac artery, aneurysm, and is expanded. And now we are thinking of 2 options. Either we are going for total endovascular, that is doing a fenestrated, because this is not an emergency, or doing a hybrid one in which we will taking doing the debranching of the viscerals and the renals, and then putting a cover stent. But for a malperfusion, if patient present with a malperfusion, our options are limited, and we have to go for the surgery. Maybe Professor Yusuf can comment on this thing. In setups which has limited endovascular skills and equipment, what will be the options?
So sometimes for, say, renal malperfusion, as I showed earlier on, one can actually just use a small stent graft, preferable self-expanding like fluency or something if you have, or even uncovered self-expanding. So we try and avoid balloon expanding stents because of the risk of the fragility. But you can just manage that by stenting that target vessel, leaving everything as it is. If this is the kidneys, then you do that. You go through the true lumen, and it's surprisingly you can get into the target vessel across the false lumen, and then you put a stent graft. So you don't have to do the entire dissection treatment to manage some of that. And people used, fenestrations in the past as well to deal with these things when the technique was not there to do the endovascular repair or major open surgery. So yes, you can do that. That's an option. So without access to a comprehensive,
Yeah. So I say if we have time, we should have discussed this, because this topic needs more of understanding, and there are a lot of areas for discussion, like new classification, how to identify false and true human, what are new ways of doing endovascular techniques. But I will say this was Professor Yusuf, that was a superb talk. You have given very practical points and very good cases, and there was a very nice discussion at the end. I thank everyone for your participation in coming this session, and I eagerly wait Professor Yusuf when he will come in Pakistan. We have meeting, and we definitely discuss more of cases and learn from him. Thank you, everyone, for coming.
My pleasure to meet all of you, and I feel very pleased and very proud to see the vascular surgery developing to such a high standard in Pakistan. So it makes me very happy.
Thank you, everyone. Assalamu alaikum.
Assalamu alaikum, and thank you very much.
Thank you, there. क्या हाल चाल है वकार, आपके खैरियत से हैं?
खालिद कैसे हो भाई? ठीक ठाक जी, तुमसे फिर बात होनी चाहिए अलग से फोन पे.
Yeah, well, it's a bit late actually, so इसलिए I couldn't get the whole talk. Okay, that's good. So इंशाल्लाह फिर बात करेंगे आपसे.
चलिए, okay.